If you are pregnant, listen up because there is an upcoming live pregnancy workshop available to help you prepare your body and pelvic floor for birth and beyond. We discuss ways to reduce risk of perineal tears and episiotomy. We learn how to reduce risk of pelvic floor trauma and, importantly, ways to support a strong postnatal recovery. This free workshop called Birth Strong is physio-created and designed to help you feel more confident and empowered about your upcoming childbirth experience. Head to fitnessmama.com/pregnancy workshop and the link is in the show notes. Once more, that's www.fitnessmama.com/pregnancy workshop, all one word. Can't wait to see you there. If you are pregnant or you've recently had a baby, this podcast is for you. I am your host, Kath Bequee, a physiotherapist working in women's health and mum of 3. Inside my online program, Fitness Mama, I just love helping support women to care for their bodies during pregnancy, prepare their bodies for birth, and support their after-birth recovery, helping them feel confident and strong inside out during this important stage of their lives. In this podcast, join me each week as we dive into all things pregnancy care, childbirth, and postnatal recovery, helping you through every step of the journey. It is absolutely possible to feel amazing and confident in our bodies during this motherhood journey, and I want that for you. Come and say hi to me on Instagram @fitnessmama, and let's dive into today's episode. May, thank you so much for joining me on the Pregnancy, Birth and Recovery podcast. We're discussing all things, as I mentioned, endometriosis, fertility, pelvic pain. As you were mentioning, it's a topic close to your heart, and I know it's one that you have amazing results with your clients that you see. So thank you so much for jumping on this call with me today.
Thank you so much for having me. Like you said, it is something that I really love, but also really hate at the same time, if it makes sense. It's like this love-hate relationship that I have with it, I think.
Yeah.
Because I'm both, like you said, a patient and a clinician. So I just, in some ways, wish that it, didn't exist, so I didn't have to feel this way. But also, I love it because I feel like I truly, truly want to make a difference in this space. So, yeah.
Yeah. And I'm sure, and correct me if I'm wrong here, but the fact that you've experienced endometriosis, no doubt it helps you to be more empathetic with your patients and understand what they're going through. And I'm sure that helps to, change the way you approach a situation as well.
I would like to think so, but I feel like at the end of the day, I think anyone who is, seeing and treating endometriosis should have that approach, because it's all about the person who you're seeing in front of you and what matters most to them at that particular time, because it is really a journey, and it's often a long journey. And one thing, when you get one thing, you have to give another thing. So it's always a balance.
Yeah, fair call. Yeah. Okay, let's get straight into it. I've got some questions that have come through from my audience and it's basically my audience when I let them know that I was doing this podcast today. And I felt it'd be great to get your input. So I'm going to just get straight into the first question.
Sure.
Let's say someone has painful periods and they're at the start of their fertility journey, but they've noticed that they've got painful periods and pelvic pain throughout the month. Can we just start at the basics? Could this be endometriosis? What is endometriosis?
So endometriosis is where the tissue that is similar to the lining of the womb is present outside of the womb. So they can be anywhere. They can be, near the bowels, near the bladder, on the pelvic sidewalls, and the ovaries. In fact, they've been found on all spots, every organ in the body. Pelvic pain and sort of period pain in a more general term encompasses that, but also period pain, or what we call primary dysmenorrhea, can be somewhat normal. It's because when we have our period, when the lining sheds, the uterus has to contract and we release these prostaglandins that can cause pain. But the degree of the pain and how much it affects our quality of life, I think, is what's important to distinguish, and whether or not these pains are associated with other forms of discomfort. For example, urinary discomfort, painful bowel motion, pain with sex, pain outside of your period time, like you said, pelvic pain. So all the other associated symptoms and how severe they are will then be the trigger to sort of go, maybe this is not just normal, umbrella term period pain. Yeah. And for someone who's sort of on their fertility journey, we always say, if you feel like there is something that is not quite right, it's always better to get it checked out. Yeah. Not to, make everyone too heightened. But it's always better to, seek help earlier than later.
Yeah. Okay. And I'd like to dive into more, but first, in terms of how does endometriosis, how does that impact chances of falling pregnant?
So endometriosis, as we know, is very complex because they can really be in any location and in varying degrees of severity. Yeah. So one important point to note is that not everyone that has been diagnosed with endometriosis will have fertility issues. And that's I think the most important message to send out. Just because you have been, given this diagnosis of endometriosis doesn't mean you will be infertile. And that's, important to know. On the flip side of that, though, sometimes endometriosis can be quite subtle in their symptoms. So we may not have a lot of pain that is debilitating, but we could be trying and trying for a baby, and then it doesn't happen. And then we realize that, actually, we've really got, quite severe endometriosis. So it can be on varying spectrum. And it can affect fertility by distorting the anatomy. So what we call frozen pelvis, and that's the most severe form of endo, where the ovaries have got endometriosis in them. The ovaries are stuck together. They're stuck to the back of the uterus. The bowels are stuck to it. Sometimes I describe it to my patients like someone's poured cement into our pelvis and it's just completely frozen. Everything's stuck. And hence, it's difficult to make good quality eggs. The eggs may not be able to travel to meet the sperm because the fallopian tubes could be damaged or scarred from the endometriosis. And the womb environment itself, because it's so inflamed, could impair implantation. So it's really depending on the location and the severity of the endometriosis lesions themselves. Some will have a more sort of widespread endometriosis, but superficial, and their pelvic organs are mobile and the ovaries are not affected. That sort of population tends to do better in terms of, how we can help fix the infertility.
Yeah.
Yeah.
So
it's very nuanced. Yeah.
Yeah, absolutely. So when someone comes to you with what could be a wide range of symptoms,
Mm.
as you mentioned, a large spectrum of potential issues. Where do you start with your assessment?
So we take a comprehensive history, and quite surprisingly, just listening to them, getting to verbalize what their symptoms are is so helpful. I've had someone tell me, you're the first person that actually listened and validated my symptoms. And I'm like, well, no, I'm technically not the first person, because the fact that your referring doctor has sent you is the first step that that person truly believes that, something is not right, and we're escalating the chain of investigations. Yeah.
Mm.
So taking a comprehensive history, knowing what affects them the most. Sometimes you can find an answer just by doing an examination, but it is involving an internal examination. So they have to be sexually active. We're sometimes able to feel, vaginal nodules or points of quite particular tenderness on, certain ligaments, or any particular points like a sort of, posterior cervical nodule. And I guess I'm getting a bit technical here, but sometimes there are things that we can feel during the vaginal examination that will give us clues. If their clinical history, plus or minus the physical examination, is suspicious, then we tend to order a specialized ultrasound. It's called a dedicated deep infiltrating endometriosis scan, performed by a qualified person that has done extra training looking for endometriosis nodules. The scan is done with a bowel prep. So we normally would, give a little laxative to just clear out the large bowels. And this gives us a much better view of, are the bowels mobile or not? Are there any adhesions? So any sort of scar tissue or sticking between the bowels and the back of the uterus, and or to the other organs, to sort of give us a clue as to how severe the endo is. And this is especially important if we're planning to have surgery, to help us plan who is required to be present at the surgery, and what needs to be done at that time. Yeah.
Yeah.
So there are some studies or publications out there saying that endometriosis can be diagnosed without a laparoscopy, and that's true in that sense. These special ultrasounds can pretty much tell you that, yep, you have, deep infiltrating endometriosis.
Yeah. So when it comes to the fertility, like the type of endometriosis that affects fertility,
Yeah.
how often could someone just have the ultrasound compared to, the scan compared to having to go with the laparoscopy?
It depends on where they are in that stage of trying. Yeah. If they're just contemplating starting to try, for example, if they're not experiencing a lot of pain, then the easiest and I guess most effective option is start trying. Yeah. If you're able to have intercourse, without significant discomfort, if you know when your fertile window is, if your cycles are fairly regular and they are manageable, even if you know that, oh, yes, there's a little bit of adhesions here, but I'm not affected by it in terms of my quality of life, the most effective ways to start trying, because the only way to know whether you've got fertility issues or not is by trying to conceive.
Yeah.
Yeah.
Yeah. So you might have just answered my next question then. If someone has been diagnosed with endometriosis or they suspect it, at what stage should they consider coming to see someone like yourself for that fertility support versus seeing, and we're going to discuss more about pelvic pain in a little bit, but seeing,
Mm,
for example, a pelvic floor physio and to manage the pain aspects.
yeah. Um, if they are, so I often ask, where are you in your fertility journey? Do you want to have children? Do you want to have children sort of in the short, medium, long term,
Yeah.
or you don't have desires to have children? And I think everyone has a choice, not
Mm.
yeah. And they say, oh no, I'm not seeing anyone, but I think I may want to have kids in the future. Then we will probably then have a discussion about fertility testing and whether or not egg freezing would be something that they would want to be thinking about. Then you want to explore the option of, do you want to manage the pain, or do you want to go down the fertility route? Because often they don't go hand in hand. If it is a laparoscopy and we diagnose the endometriosis then and we excise the endometriosis, then the excision serves as a treatment as well. So it gives them short to medium term relief of potentially their pain symptoms, and it improves their fertility by up to about 30% at that particular time. And that effect lasts for about 12 months or so. If you're not on any sort of hormonal therapy or hormonal suppression, your symptoms may come back and the endometriosis lesions could also grow back. So if they are wanting to sort of explore the pain management options and are not thinking about, having a baby at that time, then I would probably, park that to a later stage. Because once they're wanting to explore fertility treatment or trying for a baby, we have to take them off hormonal therapy. So that's where I was saying that, one doesn't quite go with the other.
Yeah.
So it's important to know where they are in that stage in their life. Do they want to, say, for example, freeze eggs first and then go on hormonal treatment, or whether, they want to have surgical management and then freeze some eggs, or, whichever way it suits the person at that particular time in their life.
So, May, I was going to ask because when
Mm,
someone comes and sees me as a pelvic floor
yes,
physio, they could be at any stage. They might have
absolutely.
self-referred
Mm,
themselves in their early 20s when,
mm,
um, babies and fertility is not even on the radar, or they
mm,
might have been referred by a GP or by an obstetrician like
mm,
yourself. So,
mm,
from your perspective, if you see someone, at what stage would you consider, I guess, that more holistic
mm,
side and
mm.
referral to a pelvic floor physio or
I
other
don't think
other
that
disciplines?
I don't think it's ever too early to refer to a pelvic floor physio, because I feel like if they're dealing with pain symptoms, and that's the most common, that's that they even front to us. If they're fairly asymptomatic, they tend not to present early until we see them, say, for example, for infertility. Because if you're asymptomatic, you wouldn't even know,
Mm,
unless you've had a scan for whatever other reason. Yeah.
yeah.
So if they're not contemplating a family, in that time, it's important to see a pelvic physio for one, I feel like optimization of their pelvic floor. Often we don't even realize it, but because we've been in pain for so long, every day, yeah,
Mm,
and we're constantly, I think, as a society, we always get told you need to strengthen your pelvic floor, you need to
mm,
do your Kegels
yeah.
exercises. But for the majority of my patients, they have a very tight pelvic floor,
Overactive. Yeah.
overactive. Yeah.
Mm.
And
And I like to, just for those listening, if you think about, sometimes an easy way to think about it is if you've got chronic headaches or neck pain, your
mm,
probably tensing up through your head and neck, shoulders. And when someone gives you a nice shoulder neck massage, you're like, oh my God, that's
Oh,
divine. Like I'm holding so much tension in those neck muscles and I don't even realize it.
yep.
It's a similar scenario. If someone's in like constant or, chronic regular pelvic pain of some description, they often hold tension in those pelvic muscles, and sometimes they're not even aware of it. And then that can cause a
Yep.
cascade of symptoms, like as you mentioned, the painful
Mm,
intercourse,
mm,
constipation. It can
yep.
exacerbate the chronic pelvic pain. It can have a whole bladder issues, bowel issues.
Mm.
So it can have a bit of a cascading effect that where sometimes if we do take a local approach with the musculoskeletal side of things and we do look at the muscle tension, as you mentioned, and breathing techniques and down training of muscles, then that can help to lower, like help with the body awareness, improve pain from that aspect, local aspect.
You're totally right because we don't even know it because we are so used to it being a particular way. And
Mm,
I often say to my patients that seeing a pelvic floor physio is not a one appointment fix. It is like running a marathon. You get into this journey with your particular person, and it is then able to optimize your, like you said, your pelvic floor muscles for more comfortable intercourse. You get better bowel and bladder function without you even knowing that you had,
mm.
oh, actually,
Issues.
you know
Yeah.
what? My bladder issue is much better, or my bowels are so much more, regular and it's not painful and I don't have to strain. And um, the diaphragm and how that affects your pelvic muscles, it's like it just
Mm,
blows my mind. But like, what?
yeah.
And then when it comes to, the next part of their lives, when they eventually do get pregnant, having that continued relationship with the pelvic physio to optimize, pregnancy discomfort, back pain,
Mm,
hip pain, and then to do pelvic floor training in preparation for birth and
mm,
perineal massage to
yeah.
prevent tearing, and then the
Yeah.
whole postpartum recovery. So their relationship with the pelvic floor physio is like the relationship
Mm,
with us, their gynecologist, their fertility specialist, their obstetrician. It's the person that will pretty much journey with them together throughout that whole reproductive stage. So
mm,
that's why I always
yeah.
say it's never too early to
Yeah.
find this person, and it's never too late to start now.
Yeah. Music to my ears. And it's also amazing how much of a link or correlation there is between the physical health, and we haven't even discussed the mental health side of things. And we can imagine if we're experiencing constipation or painful intercourse. Like these are just those two alone are
Mm.
stressful, and having pain, chronic pain, like it's stressful and it can contribute to, potentially anxiety. So, if we're helping with the musculoskeletal and the physical aspects and the general wellness and getting into fitness in a way that's supporting your pain issues, then that
Mm.
can really help with the mental health benefits too. So it's got this beautiful
It is very
uh,
interconnected, and I think as doctors, we often don't have the time, I
mm,
think, to explore and explain all that. But like you said, when you do feel better, you're sleeping better as well. And when you're sleeping
mm,
better, you're much more rested, you're less stressed. And particularly for myself, I feel like, when I'm busy and running around and I've been up all night, and when I'm coming into a cycle, the end of flare tends to be much worse.
mm.
And when I'm, going through, say, a better stage, that, I'm up to date, going to my Pilates and I'm doing my
On
exercises and I'm sleeping
holidays.
better. And yeah, on holidays, and then you need a holiday from the holiday. um,
True.
then you just know that that
Mm,
cycle is so much better, that the
yeah.
bloating is less, the pain and discomfort is less, the um the analgesia. So the pain management requirement for that particular cycle is less because I'm eating better. And just, yeah, it's
Yeah,
just
it's
all, it is very connected.
cascading.
Mm.
It's great. And this is where, as you mentioned at the very start, it's an area that I love. It's also a very complicated area, and it can have so many amazing, like when I see women with endometriosis and chronic pelvic pain, you can have such amazing, can support them to have such amazing outcomes, but it also, as you said, it's not a quick
Mm.
fix, and it's not
No.
something someone comes to you once, bit of advice, see you later. It just doesn't work like that.
And I think that's the first thing that, I tell my patients when we give them the diagnosis that one, it's a validation that what they're feeling is real. But two, also, is that now we're dealt with this card that we have a chronic condition that we don't yet have a cure for. So you need to start building your village to help you get through this the best you can because, you know, like it or not, we only have this one life and this is the life we have. So we have to make the best out of it.
Yeah, love that. So, to, I guess, wrap it up, May, is
Mm.
there anything else that we haven't discussed that you would like women to be aware of when considering, if they've got the chronic pelvic pain, or they've got the painful periods, coming into their fertility journey, perhaps? Like, is there any parting words of wisdom that you'd like to discuss?
I am so glad now that endo has, had so much, awareness around it and everyone's talking about it. Because for decades, it's just been swept under the rug like, oh, you've got period pain. It's normal.
Mm,
Just put up with it. It'll get better. Just go and have a baby. It'll get better.
yeah.
And I think the amount of times that, we've all been told these things, including myself, not knowing that, something's not quite right. And it was not until I went to medical school and it wasn't until I started training that the more I knew, the more I realized that this is not normal. It's like,
Yeah.
I've got this, I've got this, I've got this. And I think the message that I always try to get out is that if you feel like you're unheard, is to always advocate for yourself and to seek an opinion from
Mm,
someone who will listen and will investigate. Basically, someone who doesn't just brush you off. Yeah.
yeah. Yeah. Isn't it crazy? You had to go to medical school. That's not possible for everyone out there.
It,
So, yeah.
yeah. But with the current improved funding and research, and we've had, medications added onto the PBS. It's a small step, but it is a step in the right direction,
Yeah.
for more accessible women's health, accessible
Mm,
reproductive health. It's still a long way to go,
yeah.
and it's like a whole discussion altogether about funding for women's health
Mm,
versus funding for other things, but
yeah.
it is a start. And I feel like most people now would have heard of endometriosis or someone they know, because it is really that common. It affects 1 in 7 people,
Mm,
assigned female at birth. So
yeah.
it's almost like you throw a
Yeah.
stone and you could hit one of us.
Yeah.
And back in the days when I said, "Oh, do you know that these symptoms are suspicious of endometriosis?" And they're like, "What? It we've not even heard of the word. It's a long,
Mm,
complex, yeah, word." And now
yeah.
it's like, "Oh yeah, everyone knows of endo. We have endometriosis awareness month. We have
Yeah.
adenomyosis awareness month." So we're moving.
Yeah.
Um, but there's still so
Yeah.
much work to be done, and I just can't wait for the day where a cure will be found, because I will be on my knees. bowing to this person because I'm just,
Yeah.
yeah.
Yeah. Absolutely. And when you were mentioning that, I feel it's exactly the same with pelvic floor. Like no one used to really know what a pelvic floor was. And then
Yep.
everyone suddenly thought, oh, we all need to strengthen these pelvic floor muscles. So,
Yes.
Kegels are so
Yes.
important. But now we're at the stage where, it's not all about strengthening. Like
Yeah.
there's quite a big subset of women where we actually need to downtrain or need to, it's much more nuanced than that. So it's similar to
Totally. Yeah.
endometriosis. The more we discover, the more we're able to, I guess, pinpoint the appropriate course of action. So
Yeah.
amazing. Thank you so much, May, for joining me today. I know you are busy. I know you've just done ward round. I will put all your links in the show notes so that people can connect on like Instagram and your website. I appreciate the chat today.
No, seriously, Kat, like, thank you for doing all that you do. And, thank you for having me. Thanks for spreading awareness, for all your education posts. It's like, I love it. I think, the more we do, the more we can all get it out there. So, yeah.
Amazing. Thanks, May.
Thank you. I'll see you around.
Thanks for listening to the Fitness Mama podcast, brought to you by the Fitness Mama freebies found at www.fitnessmama.com/free. So please take a few seconds to leave a review, subscribe so you don't miss an episode, and be sure to take a screenshot of this podcast, upload it to your social media, and tag me at Fitness Mama so I can give you a shout out too. Until next time, remember, an active pregnancy, confident childbirth, and strong postnatal recovery is something that you deserve. Remember our disclaimer, materials and contents in this podcast are intended as general information only and shouldn't substitute any medical advice, diagnosis or treatment. I'll see you soon.